Hello dear students, my name is Dr. Məmmədzadə Aytan from Department of Internal Medicine, and today our lecture is glomerular diseases, glomerulonephritis. So the study of kidney diseases is facilitated by dividing them into those that affect their four basic morphologic components. At first is glomeruli, second is tubules, third interstitium, and four blood vessels. So in this picture you can see glomeruli in electron microscopy. Nephros is kidney. Nephros mean kidney. Itis it's inflammation. Glomus small round ball or node. Glomerulonephritis is inflammation of small round ball. Pathos is suffering or disease. Oosis is disease condition. And finally, glomerulonephritis is inflammation of the glomeruli. Glomerulopathy is disease of the glomeruli. Glomerular diseases include glomerulonephritis, it's inflammation of the glomeruli, and glomerulopathies when there is no evidence of inflammation. Glomerulonephritis is a subset of glomerulopathies. Classification of glomerulonephritis based on etiology. We have primary glomerulonephritis and secondary glomerulonephritis. Primary glomerulonephritis is immune response to pathogens. Acute glomerulonephritis, it may be acute glomerulonephritis, post-infectious glomerulonephritis, post-streptococcus glomerulonephritis, infectious glomerulonephritis, membranoproliferative glomerulonephritis, rapidly progressive glomerulonephritis, idiopathic membranous glomerulonephritis, immunoglobulin A or IgA nephropathy, chronic glomerulonephritis, focal glomerular sclerosis. Secondary glomerulonephritis include next syndrome, and there is a related to systemic disease. Goodpasture syndrome, hemolytic uremic syndrome, polyarteritis, progressive systemic sclerosis, systemic lupus erythematosus, Wegener granulomatosis, so vasculitis, thrombocytopenic purpure, postpartum renal failure. Primary glomerular diseases. Primary glomerulopathies is, and I said it's acute proliferative glomerulonephritis, post-infectious and other, rapidly progressive or crescent glomerulonephritis, membranous glomerulopathy, minimal change disease, focal segmental glomerular sclerosis, membranoproliferative glomerulonephritis, IgA nephropathy, chronic glomerulonephritis. In clinical practice, glomerulonephritis has four major pathogenetic forms of glomerular injury: in non-proliferative glomerulopathy and in proliferative glomerulopathy. In non-proliferative glomerulopathy, we have damage by antibodies, damage mediated by complement. In proliferative glomerulopathy, we have damage by circulating pro-inflammatory cells, especially neutrophils and macrophages, and damage by locally activating resident cells, for example, mesangial cells. In this table you can see pathogenesis of glomerular disease. At first we have immune disorder, next kidney involvement, and next injury by inflammation and other mediators, and glomerular dysfunction. When we have immune disorder, also we have circulating immune complex with immune complex formation and cell-mediated, and finally glomerular dysfunction. What we can talk about clinical manifestations. The clinical manifestation of glomerular disease are clustered into the 5 major glomerular syndromes summarized in table. It's 5 major syndrome: nephrotic syndrome, manifestation with hematuria, azotemia, variable proteinuria, oliguria, edema and hypertension; rapidly progressive glomerulonephritis, acute nephritis, manifestation with acute nephritis, proteinuria and acute renal failure; nephrotic syndrome, more than 3.5 gram per day proteinuria, hypoalbuminemia, hyperlipidemia, lipiduria; chronic renal failure, azotemia to uremia progressing for months to years, and isolated urinary abnormalities, so when patient has glomerular hematuria and or subnephrotic proteinuria. Histological alteration of glomerulonephritis. Various types of glomerulopathies are characterized by one or more of 4 basic tissue reactions: hypercellularity, basement membrane thickening, hyalinosis, and sclerosis. So next we will talk about various forms of glomerulonephritis. At first, it's minimal change disease or lipoid nephrosis, characterized by benign disorder, most common in 1 to 7 years with nephrotic syndrome. Pathogenesis, a T-cell derived factor that causes podocyte damage and effacement of food process. Morphology of lipoid nephrosis, you can see in this picture by microscopy the uniform and diffuse effacement of the food processes of the podocytes. Clinical features. Nephrotic syndrome is an otherwise healthy child. The patient has selective proteinuria, chiefly albumin, and more than 19% of cases respond to corticosteroid therapy. So in this picture you can see a child with nephrotic syndrome with lipoid nephrosis, and he has edema on his face and a foot. Second form of glomerulonephritis is focal and segmental glomerulosclerosis, or FSGS. FSGS is characterized histologically by sclerosis affecting some glomeruli, focal involvement, and involving only segments of each affected glomerulus. FSGS is associated with nephrotic syndrome. Pathogenesis is unknown, part of a continuum, maybe MCD to FSGS, distinct entities. Injury to the podocytes is thought to represent the initiating event of primary FSGS. The involvement is focal and segmental. The affected glomeruli exhibit increased mesangial matrix, obliterated capillary lumens, and lipid droplets, which shows effacement of food processes. Global sclerosis may be found accessionally. and collapsing glomerulopathy, collapse of the entire glomerular tuft, and podocyte hyperplasia. Response to corticosteroid is poor, and spontaneous remission of idiopathic FSGS is rare, and about 15% individuals suffer renal failure after 10 years. So, next form of glomerulonephritis is membranous glomerulonephritis, characterized morphologically by the presence of subepithelial immunoglobulin-containing deposits along the GBM. This is slowly progressive disease, most common between 13 and 15 years of age. Well-developed cases show diffuse thickening of the capillary wall. Membranous glomerulonephritis may be idiopathic. It's about 85–19%. Secondary 10–15%. Secondary to other disorders, after infections, malignant tumors, autoimmune conditions, exposure to inorganic salts and drugs. Pathogenesis of membranous glomerulonephritis based on chronic immune complex nephritis. Most idiopathic forms are induced by antibodies reaction in situ to endogenous antigen and autoimmune disease, activation of MAC to activation of mesangial cell and podocytes, liberate proteases and oxidants, damage capillary walls, and perturbation in filtration. Morphology of membranous glomerulonephritis you can see in this picture by microscopy. Diffuse thickening of the basal membrane, subepithelial deposits, spike and dome pattern, effacement of food processes, and immunofluorescence microscopy, granular deposits. Clinical manifestation of membranous glomerulonephritis with membranous glomerulonephritis characterized by nephrotic syndrome, non-selective proteinuria, does not respond to corticosteroids, variable and indolent CARs. So next it's membranoproliferative glomerulonephritis, mesangiocapillary or mesangiocapillary glomerulonephritis. Membranoproliferative glomerulonephritis is characterized histologically by alteration in the basal membrane, proliferation of glomerular cells, and leukocyte infiltration. Because the proliferation is predominantly in the mesangium, but also may involve the capillary loops, a frequently used synonym is mesangiocapillary glomerulonephritis. And so we have mesangioproliferative or mesangiocapillary glomerulonephritis. Mesangioproliferative glomerulonephritis accounts for 10–20% of cases of nephrotic syndrome in children and young adults. Types of primary mesangiopproliferative glomerulonephritis is type 1 or primary MPGN, type 2 or secondary MPGN, and type 3 or mixed mesangiopproliferative glomerulonephritis. Pathogenesis of type 1. In most cases of type 1 mesangiopproliferative glomerulonephritis, there is evidence of immune complexes in the glomerulus and activation of both classical and alternative complement pathways. The antigens involved in idiopathic membranoproliferative glomerulonephritis are unknown. In many cases, they are believed to be proteins derived from infection agents such as hepatitis C and B viruses. Most patients with dense deposit disease. Type 2 mesangial proliferative glomerulonephrite have abnormalities that suggest activation of the alternative complement pathway. So, these patients have a consistently decreased serum complement 3 but normal complement 1 and complement 4. Pathogenesis type 2, they also have diminished serum levels of factor B and properdin components of the alternative complement pathway. In the glomeruli, complement 3 and properdin are deposited, but immunoglobulin G is not. More than 17% of patients with dense deposit disease have a circulating antibody termed complement-3 nephritic factor, which is an autoantibody that binds to the alternative pathway complement-3 convertase. Binding of the antibody stabilizes the convertase, protecting it from enzymatic degradation and thus favoring persistent complement-3 activation and hypercomplementemia. By light microscopy, both types of mesangial proliferative glomerulonephrite are similar. The glomeruli are large and hypercellular. Crescents are present in many cases. The glomeruli have an accentuated lamellar appearance due to the proliferating mesangial cells and increased mesangial matrix. Within the duplicated basement membranes, there is inclusion of interposition of cellular elements, appearance of split basement membranes. Types 1 and 2 mesangial proliferative glomerulonephrite differ in their ultrastructure and immunofluorescent features. Type 1 mesangial proliferative glomerulonephrite is characterized by the presence of discrete subendothelial electron-dense deposits. By immunofluorescence, complement-3 is deposited in a granular pattern, and immunoglobulin G and early complement components are often also present, suggesting an immune complex pathogenesis. So, in this picture you can see it's a light microscopy. So it's membranoproliferative glomerulonephritis, showing mesangial cell proliferation, increased mesangial matrix staining black with silver stain, basement membrane thickening with segmental splitting here, acute of lamellar architecture, swelling of cell lining, peripheral capillaries, and influx of leukocyte. So it's capillary proliferation. Here, picture A, membranoproliferative glomerulonephritis type 1, not discrete electron-dense deposits incorporated into the glomerular capillary wall between split basement membranes, double arrows, yeah, and in mesangial regions here, M, capillary lumen. Picture B, dense deposit disease type 2 membranoproliferative glomerulonephritis, the markedly dense homogeneous deposits within the basement membrane proper. In both mesangial interposition G gives the appearance of split basement membranes when viewed in the light microscopy. And picture C, schematic representation of patterns in the two types of membranoproliferative glomerulonephritis, this type 1 and this type 2. In type 1, there are subendothelial deposits. Type 2 is characterized by intramembranous dense deposit disease. In both, mesangial interposition gives the appearance of split basement membranes when viewed in the light microscopy. Clinical manifestation, clinical features of this form, membranous glomerulonephritis. Next, most patients present in adolescents or as young adults with nephrotic syndrome and a nephrotic component manifested by hematuria or more insidiously as mild proteinuria. Few remissions occur spontaneously in either type, and the disease follows a slowly progressive but unremitting course. Some patients develop numerous crescent and a clinical picture of rapid membranous glomerulonephritis. About 15% develop chronic renal failure within 10 years. Treatments with steroids, immunosuppressive agents, and antiplatelet drugs have not been proved to be materially effective. There is a high incidence of recurrence in transplant recipients, particularly in dense deposit disease. Dense deposits may recur in 19% of such patients, although renal failure in the allograft is much less common. Secondary membranous proliferative glomerulonephritis, variable type 1, is more common in adults and arises in the following settings: chronic immune complex disorders such as systemic lupus erythematosus, hepatitis B infections, hepatitis C infection, usually with cryoglobulinemia, endocarditis, infected ventricular arterial shunts, chronic visceral abscesses, HIV infection, and schistostomatosis. Alpha-1 antitrypsin deficiency, malignant diseases, chronic lymphocytic leukemia and lymphoma, hereditary deficiency of complement regulatory proteins. IgA nephropathy. IgA nephritis or Berger's disease, Berger syndrome, and synpharyngitic glomerulonephritis is a form of glomerulonephritis. IgA nephropathy, Berger's disease, characterized by the presence of prominent IgA deposits in the mesangial regions detected by immunofluorescence microscopy. IgA nephropathy is a frequent cause of recurrent growth of microscopic hematuria and is probably the most common type of glomerulonephritis worldwide. In IgA nephropathy, plasma polymeric IgA is increased and circulating IgA containing immune complexes are present in some patients. Only immunoglobulin A1 forms the nephrogenic deposit of IgA nephropathy. IgA nephropathy, Berger disease. The prominent mesangial deposition of IgA suggests entrapment of IgA immune complex in the mesangium and the presence of complement-free combined with the absence of complement 1q and 4 in glomeruli points to activation of the alternative complement pathway and innate glomerular injury. A genetic influence is suggested by the occurrence of this condition in families and in HLA identical brothers and the increased frequency of certain HLA and complement genotypes in some population. On histologic examination, the lesions vary considerably. The glomeruli may be normal or may show mesangial widening and endocapillary proliferation, mesangial proliferative glomerulonephritis, segmental proliferation confined to some glomeruli, focal proliferative glomerulonephritis, or rarely overt crescentic glomerulonephritis. The characteristic immunofluorescent picture is of mesangial deposition of IgA, often with complement-free and propertin, and lesser amounts of immunoglobulin G or immunoglobulin M. Early complement components are usually absent. So it's IgA nephropathy by light microscopy showing mesangial proliferation and leukocyte increase. And in picture B you can see deposit of immunoglobulin A, principal in mesangials, and damage by antibodies. The disease affects people of any age, but older children and young adults are most commonly affected. Many patients present with gross hematuria after an infection of the respiratory or less commonly gastrointestinal urinary tract. 13 to 14% have only microscopic hematuria with or without proteinuria, and 5 to 10% develop atypical acute nephrotic syndrome. The hematuria typically lasts for several days and then subsides, only to return every few months. The subsequent course is highly variable. Many patients maintain normal renal function for decades. Slow progression to chronic renal failure occurs in 15 to 14% of cases over a period of 20 years. Onset in old age, heavy proteinuria, hypertension, and the extent of glomerular sclerosis on biopsy are close to an increased risk of progression. Recurrence of immunoglobulin A deposits in transplanted kidneys is frequent. In approximately 15% of those with recurrent IgA deposits, there is a resulting clinical disease, which most frequently runs the same slowly progressive course as that of the primary immunoglobulin A nephropathy. Acute proliferative or post-streptococcal glomerulonephritis, characterized histologically by diffuse proliferation of glomerular cells associated with influx of leukocytes. These lesions are typically caused by immune complexes. The inciting antigen may be exogenous, post-infection glomerulonephritis, or endogenous, systemic lupus erythematosus. Acute proliferative glomerulonephritis, the most common underlying infections are streptococcal, but the disorder also has been associated with other infections. It usually appears 1 to 4 weeks after streptococcal infection of the pharynx or skin. It occurs most frequently in children 6 to 10 years of age, but adults of any age can also be affected. Etiology and pathogenesis of this form glomerulonephritis. Only certain strains of group A beta hemolytic streptococci are nephrogenic, more than 19% of cases being traced to types 12, 4, and 1, which can be identified by typing of M protein of the cell wall. Post-streptococcal glomerulonephritis is an immunologically mediated disease. Elevated titers of antibodies against one or more streptococcal antigens are present in a great majority of patients. Serum complement levels are low. There are granular immune deposits in the glomeruli, supporting an immune complex mediated mechanism. Several cationic antigens, including a nephritis-associated streptococcal plasmin receptor, unique to nephrotogenetic strains of streptococci, can be found in affected glomeruli. Streptococcal pygonic exotoxin B and its zymogen precursor are the principal antigenic determinant in most cases of post-streptococcal glomerulonephritis. Acute glomerulonephritis or post-streptococcal glomerulonephritis is commonly caused by infection by certain strains of group beta hemolytic streptococci after pharyngitis or pyoderma, and again streptococci react with women-teen to immunocomplexes. Nephritis develop after a latent period of about 2-3 weeks, and acute post-streptococcal glomerulonephritis characterized by nephritic syndrome and histologic pattern intracapillary proliferation of mesangial and endothelial cells with subepithelial or humps and subendothelial deposits, complement-free or immunoglobulin G. Here you can see its light and electron microscopy of acute post-streptococcal glomerulonephrite, and immunocomplexes and leukocyte deposits in basal membrane. And post-infectional non-streptococcus glomerulonephritis. Acute glomerulonephritis can develop also in the course of other infections. It may be staphylococci, pneumococci, Klebsiella pneumonia, herpes virus, Epstein-Barr virus, virus hepatitis B, and it may be a glomerulonephritis in infection endocarditis, in visceral abscesses, especially lung. Histologic pattern and clinical syndrome, similar one as in post-streptococcal glomerulonephritis. So you can see pathogenic mechanism in this picture. You can see pathogenic mechanism of glomerular disease, always glomerular disease with nephritic and nephrotic syndrome. And 0 with it's nephrotic. So at first we have inflammatory, second immune and podocyte injury with it may be in minimal change disease, liponephrosis, or focal segmental glomerulosclerosis, subepithelial deposits in systemic lupus erythematosus, streptococci, hepatitis B, membranous nephropathy, metabolic and toxic after diabetes mellitus and amyloidosis, and all of these form glomerular disease characterized by nephrotic syndrome. But it may be other situation, and inflammatory to immune, and in Goodpasture syndrome or antiglomerular B nephritis, basal membrane nephritis, or ANCA positive disorders when we have podocyte injury. Second, subepithelial deposits, it may be in systemic lupus erythematosus or post-infection glomerulonephritis. It may be post-streptococcal or glomerulonephritis, bacterial endocarditis, hepatitis B virus, malaria, and Behçet and IgA nephropathy after Schleien-Henoch purpur. And inflammatory to vascular in vasculitis and pouch immune necrotizing glomerulonephritis. It's idiopathic crescentic, and it may be thrombotic mesangiopathies, malignant hypertension, and collagen 4 hereditary defect in Alport syndrome. And so pathogenesis of nephrotic disease. If we have next etiological factors, so production of GBM antibodies, immunoglobulin fix and activate complement, circulating antigen antibody complexes, immediate effects, which immediate effects we have, it's membrane type E, glomerular basement membrane damage, and we have effects on glomerular function. It's breaking through filter integrity podicity. It's increased and with hematuria and proteinuria. Second, so we have circulating antigen antibody complexes. Two immediate effects, we have infiltration of glomeruli with cytokines, and so it go to glomerular cell proliferation, and with crescent formation cellular edema, and to filter blocking permeability, and to increased GFR and hypervolemia with hypervolemia, edemas, hypertension, azotemia, and uremia. But pathogenesis of nephrotic disease, it's nephrotic syndrome, and nephrotic syndrome, so it may be glomerular permeability to peripheral capillaries permeab, and proteinuria, hypoproteinemia, hyperlipidemia, and edema. So loss of lipoprotein lipase, to hyperlipidemia, and also liver lipoprotein synthesis, and proteinuria to hypoproteinemia, and intravascular oncotic pressure to edema, and peripheral capillaries permeab to filtration of proteins into interstitium to edema, and increased natrium retention to hypervolemia and edema. So is enlarged hypercellular glomeruli. Morphology of acute post-streptococcal glomerulonephritis. There is also swelling of endothelial cells, and the combination of proliferation, swelling, and leukocyte infiltration obliterates the capillary lumens. There may be interstitial edema and inflammation, and the tubules often contain red cell casts. By immunofluorescence microscopy, there are granular deposits of immunoglobulin G, immunoglobulin M, and complement-free in the mesenchyme and along the basal membrane. The characteristic electron microscopic findings are discrete, amorphous, electron-dense deposits on the epithelial side of the membrane, often having the appearance of humps. So, in this picture, you can see four fragments. A is normal glomerulus. B, it's glomerulus in acute proliferative glomerulonephritis, intracapillary leukocytes, and proliferation of intracellular cells. And C, it's electron-dense subepithelial hump and a neutrophil in the lumen. And in D, you can see immunofluorescence stain demonstrates. So immunofluorescence states, and it's protein and infiltrated by protein in these glomeruli. Clinical manifestation, clinical features of acute post-streptococcal glomerulonephritis. In the classic case, a young child abruptly develops malaise, fever, nausea, oliguria, and hematuria. 1 to 1 to 2 weeks after recovery from a sore throat. The patients have red cell counts in the urine, mild proteinuria, usually less than 1 gram per day, periorbital edema, and mild to moderate hypertension. Clinical features of acute pyelonephritis in adults. The onset is more likely to be atypical, such as the sudden appearance of hypertension or edema, frequently with elevation of bone. So, during epidemics caused by nephrogenic streptococcal infection, glomerulonephritis may be asymptomatic, discovered only on screening for microscopic hematuria. Elevation of anti-streptococcal antibody titers and a decline in the serum concentration of complement-free and other components of the complement cascade. Prognosis of acute post-streptococcal glomerulonephritis: more than 95% of affected children eventually recover totally with conservative therapy aimed at maintaining sodium and water balance. A small minority of children, perhaps fewer than 1%, don't improve, become severely oliguric, and develop a rapidly progressive form of glomerulonephritis. Next case is non-streptococcal acute glomerulonephritis, post-infectious glomerulonephritis, but non-streptococcal infectious. Glomerulonephritis occurs sporadically in association with other infections, including bacterial, viral, and parasitic. Granular immunofluorescent deposits and subepithelial humps are present, and 70 a rapidly progressive or crescentic glomerulonephritis. Rapidly progressive crescentic or crescentic glomerulonephritis is a syndrome associated with severe glomerular injury and does not denote a specific etiologic form of glomerulonephritis. It's characterized clinically by rapid and progressive loss of renal function associated with severe oliguria and signs of nephrotic syndrome. If untreated, this from a renal failure occurs within weeks to months. The most common histologic picture is the presence of crescents in most of the glomeruli, crescentic glomerulonephritis. Crescents are produced by the proliferation of the parietal epithelial cells lining Bowman capsule and by the infiltration of monocytes and macrophages. Classification and pathogenesis of non-streptococcal rapid progressive glomerulonephritis may be caused by a number of different diseases, some restricted to the kidney and others systemic. Although no single mechanism can explain all cases, there is little doubt that in most cases the glomerular injury is immunologically mediated. A practical classification divides rapid progressive glomerulonephritis into 3 groups on the basis of immunological findings. In each group, the disease may be associated with a known disorder or it may be idiopathic. In the table, you can see classification and differential diagnostic difference between different forms of glomerulonephritis. So, rapidly progressive glomerulonephritis type 1 anti-GBM antibody, renal limit, maybe in good posture syndrome. Type 2, it's immune complex. It may be idiopathic, it may be post-infectious glomerulonephritis, lupus nephritis by lupus erythematosus, Henoch-Schönlein purpur, IgA nephropathy, and others. Type 3, pouch immune, ANCA-associated, after ANCA-associated vasculitis, idiopathic Wegener granulomatosis, and microscopic polyangiitis. It's type 3. The first type of rapid progressive glomerulonephritis is anti-GBM antibody induced disease characterized by linear deposits of immunoglobulin G and in many cases complement-free in the GBM that are visualized by immunofluorescence. In some of these patients, the anti-GBM antibodies cross-react with pulmonary alveolar basement membranes to produce a clinical picture of pulmonary hemorrhage associated with a renal failure. It may be in good posture syndrome. The second type of rapid proliferative glomerulonephritis is a result of immune complex deposition. It can be a complication of any of the immune complex nephritis, including post-infectious glomerulonephritis, lupus nephritis, IgA nephropathy, and Henoch-Schönlein purpur. Classification and pathogenesis: crescentic, bicrescentic, or rapid progressive glomerulonephritis. The third type of rapid progressive glomerulonephritis, also called pouchy immune type, is defined by the lack of anti-GBM antibodies or immune complexes by immunofluorescence and electron microscopy. To summarize, all three types of rapid progressive glomerulonephritis may be associated with a well-defined renal or extrarenal disease, but in many cases, about 50%, the disorder is idiopathic. Of the patients with this syndrome, about 1/5 have anti-GBM antibody-mediated glomerulonephritis without lung involvement. Another 1/4 have immune complex-mediated crescentic glomerulonephritis, and the remainder are of the pouchy immune type. The common denominator in all types of rapid progressive glomerulonephritis is severe glomerular injury. Morphology of rapid progressive glomerulonephritis: the kidneys are enlarged and pale, often with petechial hemorrhages of the cortical surfaces, and depending on the underlying cause, the glomeruli may show focal necrosis, diffuse or focal endothelial proliferation, and mesangial proliferation. So, crescents are formed by proliferation of parietal cells and by migration of monocytes and macrophages into the urinary space. Fibrin strands are frequently prominent between the cellular layers in the crescent. By immunofluorescence microscopy, immune complex-mediated cases show granular immune deposits. Good-posture syndrome cases show linear GBM fluorescence for immunoglobulin and complement, and pouch immune cases have little or no deposition of immune reactions. Electron microscopy discloses deposits in those cases due to immune complex deposition, is type 2. Regardless of type, electron microscopy may show distinct ruptures in the GBM, the severe injuries that allows leukocytes, proteins, and inflammatory mediators to reach the urinary space, where they trigger the crescent formation. So in this picture you can see it's light microscopy. Crescentic glomerulonephrite are stained, not the collapsed glomerular tufts and the crescent-shaped mass of proliferating parietal epithelial cells and leukocytes internal to bone capsule. Here and here. It's crescentic glomerulonephritis. Its electron microscopy show characteristic ringing of leukocytes with focal. It's focal. This and this. Clinical manifestation, clinical course of this form glomerulonephritis has next symptoms. It's hematuria, the blood in urine, red blood cell casts in the urine, and moderate proteinuria, hypertension, and edema. In Goodpasture syndrome, the course may be dominated by recurrent hemoptysis or even life-threatening pulmonary hemorrhage. So, this here you can see different form of glomerulonephritis with different kidney syndromes. Minimal change characterized by nephrotic syndrome, and rarely by nephrotic syndrome. Membranous nephropathy also, amyloidosis with nephrotic syndrome, focal segmental glomerulosclerosis with nephrotic syndrome, but sometimes we can see with nephrotic syndrome. Mesangic proliferative glomerulonephritis with nephrotic syndrome and nephritic syndrome. Membranoproliferative glomerulonephritis always about 19% with nephritic syndrome. Proliferative glomerulonephritis about 90-95% with nephritic syndrome. Acute proliferative glomerulonephritis with nephritic syndrome, and crescentic glomerulonephritis with 90-95% with nephritic syndrome. So, chronic glomerulonephritis, a pool of end-stage glomerular disease caused specific types of glomerulonephritis. Post-streptococcal glomerulonephritis in adults, crescentic glomerulonephritis, membranous nephropathy, mesangic proliferative glomerulonephritis, IgA nephropathy, and focal segmental glomerulonephritis, glomerulosclerosis. So, primary glomerular diseases leading to chronic glomerulonephritis. It may be post-streptococcal glomerulonephritis. It may be crescentic glomerulonephritis, membranous nephropathy, focal segmental glomerulosclerosis, membranoproliferative glomerulonephritis, IgA nephropathy, and others. So, approximately post-streptococcal about 2% go to chronic glomerulonephritis. Rapidly progressive, crescentic glomerulonephritis about 19%, it's very big percent. Membranous nephropathy 13 to 15%. Focal segmental glomerulosclerosis about 17-18%. Membranoproliferative glomerulonephritis about 15%. And IgA nephropathy about 13 to 15%, and other form of glomerulonephritis it's not very big percents. A variable percentage of cases arise mysteriously with no antecedent history of any of the well-recognized forms of acute glomerulonephritis. The kidneys are symmetrically contracted and have diffusely granular cortical surfaces. On section, the cortex is symmetric and there is an increase in peripelvic fat. In early cases, the glomeruli may still show evidence of the primary disease. However, there eventually ensues obliteration of glomeruli, transforming them into acellular eosinophilic masses. Arterial and arterial sclerosis, marked atrophy of associated tubules, irregular interstitial fibrosis, mononuclear leukocytic infiltration of the interstitium. All of them you can see in chronic glomerulonephritis. So, dialysis changes: arterial and intimal thickening, focal calcification, extensive deposition of calcium oxalate crystals in tubules and interstitium, acquired cystic disease, increased numbers of renal adenomas and adenocarcinomas, uremic pericarditis, uremic gastroenteritis, secondary hyperparathyroidism, left ventricular hypertrophy, and uremic pneumonitis. So, chronic glomerulonephritis, shows complete replacement of virtually glomeruli by blue staining color. It's chronic glomerulonephritis. You can see glomerular with after the crescent glomerulonephritis. Mostly, chronic glomerulonephritis develops insidiously and slowly progresses to renal insufficiency or death from uremia. Frequently, patients have loss of appetite, anemia, vomiting, or weakness. In some, the renal disease is suspected with the discovery of proteinuria, hypertension, or azotemia on routine medical examination. In others, the underlying renal disorder is discovered in the course of investigation of edema. And most patients are hypertensive, and sometimes the dominant clinical manifestation are cerebral or cardiovascular. So thank you for attention and see you later.